This videoscribe will cover the condition of equine mastitis. Mastitis is a common condition affecting all domestic mammals. It appears to be less common in the horse than in other species. Put simply, mastitis is inflammation and/or infection of the udder. The variation in incidence of mastitis in mares compared to other domestic species may be explained by the anatomy of the mammary gland. In the mare, the udder is positioned high up against the abdominal wall and is not as pendulous as it is in other species. These factors render the equine udder and teats less likely to be subjected to trauma and infection than species where the udder is larger and closer to the ground. As such, the mare's udder has a smaller storage capacity, resulting in frequent feeding of the neonate, which may also be protective against mastitis. Equine mastitis usually occurs during lactation. Mares can be affected at any stage of lactation, and there have been case reports of non-lactating maiden mares with mastitis. The incidence of mastitis increases during the early postpartum period due to the physiological changes in the mammary gland, potential teat trauma from the foal, and the presence of milk, which can serve as a medium for bacterial growth. Risk factors for mastitis in the mare include poor hygiene in the mare's environment, trauma to the udder or teats, teat malformations or prior infections, failure of the foal to nurse adequately leading to milk accumulation, and weaning when milk is no longer being regularly removed. Whilst uncommon, there can be severe consequences associated with mastitis in the mare. Transmission of an infectious agent to the nursing foal may result in septicemia and other associated diseases. Additionally, agalactia can lead to subsequent foal malnutrition, which may require intensive management for foal milk supplement or require substitution of the mare with a nurse mare. In severe cases, permanent loss of function to the affected quarter may occur due to severe glandular fibrosis resulting in obstruction. The presentation of equine mastitis can vary from mild to severe and includes reluctance to allow nursing, firmness, swelling and warmth of one or both mammary glands, pain or sensitivity in the udder on palpation, lameness or reluctance to move, changes in milk appearance, for example, thick, discoloured, clotted or bloody milk, agalactia, fever, lethargy and inappetence in severe cases. The primary causative agents of mastitis are bacteria that are found in association with the skin. Streptococcus species are by far the most common isolates, with both gram-positive and gram-negative isolates being identified in the literature, including but not limited to Streptococcus zooepidemicus, which is the most prevalent, E. coli, Staphylococcus aureus, Klebsiella species and Pseudomonas species. It is thought that these organisms gain entry to the mammary gland via an ascending infection through the teat. Poor mammary hygiene or direct trauma can facilitate entry. Once inside, pathogens begin to multiply, prompting a local immune response. Neutrophils infiltrate the mammary tissues, releasing cytokines and enzymes that, while targeting pathogens, also damage mammary epithelial cells. This leads to swelling and heat due to increased blood flow, pain and tenderness from inflammatory mediators, disruption of normal milk production, and, in severe cases, abscess formation or systemic illness. A diagnosis of mastitis can be achieved by physical examination and identification of the clinical signs. Assessment of the mammary secretions may also further support the working diagnosis of mastitis by examining the colour, consistency and odour. Affected milk is often discoloured, yellow, green or bloody, and may clot. Cytological examination of the mammary gland's secretion also supports the diagnosis, with high numbers of neutrophils with degenerative changes supporting a presumptive diagnosis of mastitis. It is recommended to confirm the presence of bacterial agents by performing aerobic culture of the mammary secretions. When collecting mammary secretions for culture and susceptibility testing, it is important that sterile gloves are worn and that the first secretions from the gland are discarded to avoid contamination from the distal teat canal, thereby obtaining a sample directly from the affected gland. Blood work may be useful in monitoring cases of clinical mastitis. Haematology is likely to show a leukocytosis and neutrophilia. Increased inflammatory markers have potential diagnostic and monitoring use. Ultrasonography is useful to differentiate mastitis from udder abscessation, neoplasia, and trauma. Ventral edema, just cranial to the mammary gland, is common in late gestation and should be considered as a differential when mammary enlargement is reported in late pregnancy. Early and aggressive treatment is essential to reduce pain, restore milk flow, and prevent chronic damage or systemic complications. Mastitis therapy includes systemic and local antimicrobial therapy, non-steroidal anti-inflammatory medication in combination with frequent milk or stripping of the affected gland, hot packing, and hydrotherapy. In a review from North America, trimethoprim sulfur therapy was effective against more than 75% of bacterial isolates, while penicillin was effective against less than 60% of isolates. Stripping the mammary gland is necessary to remove bacteria and necrotic debris from the affected gland. Hot packs and cold hosing can help reduce edema and promote drainage. Treatment goals include eradicating the infection, reducing inflammation and pain, and supporting the mare systemically. Choice of antimicrobials should be based on culture and susceptibility results. However, treatment is usually initiated prior to results due to the nature of the condition. Broad-spectrum antimicrobials should be selected initially and tailored to suit the susceptibility results. In many cases, an intramammary preparation is infused once into the teat of the affected gland to initiate local treatment along with systemic antibiotic therapy. However, caution should be exercised as this can be painful and therefore dangerous to the administrator. In terms of prognosis, cases of acute clinical mastitis often respond quickly to appropriate therapy. Recurrence is uncommon with the mammary gland returning to a normal anatomy and function. Chronic, severe, or recurrent cases have been associated with fibrosis of the gland and potential reduction in milk production. Surgical resection of the mammary gland has been described for cases refractory to medical treatment, but is very rarely necessary.